I am sitting here with a whole room full of people from Westshore Primary Care, and we will be introducing them in just a minute. I did want to tell you that this webinar is offered in conjunction with the Ohio Department of Health, and the webinars are in part of a larger grant to the state from the Center for Disease Control and Prevention, or CDC. There are a list of upcoming webinars at the back of this, and as Scott mentioned, if you'd like to get a copy of this or any other webinar, just go to our YouTube channel. All right, what we're covering today is a topic that seems to be one of the most asked about areas that we are dealing with today, and that is chronic care management and how to set up a program for it. We know that this is an issue because CMS established the program and the billing for it at the beginning of 2015, and at the end of 2015, literally only 1% of potential providers that could have used the billing had done so. And so I think there's a lot of interest, but a lot of questions on how to do it. So what we've done is, this is still a work in progress, but we are working very closely with Westshore Primary Care, who has instituted a program and has really done it in a fine job as a team approach, and we'll ask them how they got it up and running. To start us off, I'd like to introduce you to Dr. Michael Adornetto, who was one of the founders, the original founders almost 30 years ago, Westshore Primary Care, and has grown it into a wonderful primary care network in western Cuyahoga County and Lorain County. And we'll let Dr. Adornetto talk about the practice and introduce his team, because we do have a whole team here.
Thank you. First off, I am the president of Westshore Primary Care, and I was one of the original members of an independent group. And over the years, we have transitioned to be more closely aligned with the St. John Medical Center, which then more recently, within the last 9 months, has been fully acquired by University Hospitals. We'll talk a little bit about this because we function mostly as an independent group reporting to the hospital. So a lot of what we'll talk about is really from an independent standpoint. With me today is Dr. Jason Ridgel, MD, who is the Director of Medical Informatics for our group. He really was very much involved in getting our EMR up and running and customizing it for physicians and making it easy to use, and has been very instrumental in getting this program started. Irene Nico Barakis, she is a nurse practitioner who's joined us and has been part of our group to initially expand our offerings and extending our hours, and then transitioned into this role more recently as we started the program. Lynn Foles and Nancy Lemke are from our billing department. Nancy Lemke has run our billing department for as long as I can remember, and Lynn Foles has been very integral in helping establish the rules for this program. Kaye Gorman is with us, and she's our Director of Information Technology, and she can talk a little bit about the technical aspects of the program. Our group's been around for, as Cathy said, over 25, closer to 30 years, first as a small group, then growing into a much larger primary care network. And we are in western Cuyahoga County, eastern Lorain County. Much of what we do is really just primary care related, although we do have some specialties. So I think that kind of gives you an idea of what our group is all about, and I'll let Cathy take it from here.
Thank you, Dr. Adornetto. And I have one other person to introduce, and that is Lisa Martin, who is our Community Outreach Manager. And Lisa, would you like to, you want to wait until you get to your slide to talk about what you do with practices?
Sure.
Okay. With that, we're going to look first at what CMS requires if you want to provide chronic care services for your practice, or I mean for your patients, for Medicare or for Medicaid fee-for-service, what exactly would be entailed. And the concept of chronic care management is basically a holistic approach to taking care of the patient. So rather than just billing for illness or wellness, you are looking at how you can coordinate this in the community and with the patient in between the time that you provide face-to-face services. Usually chronic care management programs are run by primary care practices, and the reimbursement is done for that coordination and not necessarily for any individual clinical care that is provided. What CMS requires is specific, and I think this is why a lot of practices have been slow to get into this area. So the requirements are that in order to trigger the care for a patient who's going to enter your chronic care program, you must have a comprehensive E&M visit, evaluation management, an annual wellness visit, or a preventive physical exam. At that time, you need to get the patient's written consent to participate in the program. You must identify at least 2 chronic conditions that the patient is suffering from or has that can include any one of a number of conditions. CMS gives a list of conditions as examples, such as diabetes and hypertension, COPD, behavioral health issues, but they make a point of saying that the list is not limited to their examples, but rather to any 2 conditions that the physician or practitioner would identify. The data on the patient must be available within the EHR system. There must be a care plan developed, and that this then becomes the basis for the work by the chronic care manager. The record must be accessible and the care must be accessible on a 24/7 basis for the practitioner, and there must be continuity of care. And if this sounds like a patient-centered medical home, there are a lot of similarities here. So it is similar to PCMH on the 24/7 access and the use of a coordinated care plan member. There needs to be an assessment of needs, and you must use electronic means for transitions of care or referral. To bill for the chronic care management, you must have 20 minutes of care provided in a calendar month. The care cannot be billed in the same 30-day period that transitional care management is billed. And if you are not using transitional care management, what we're referring to here is the follow-up that is done on a patient as they are discharged from the hospital. That has its own set of requirements, but as we will get into it, you will see that Westshore has been able to blend the approach in working with the patients between these 2 different programs. But transitional care management is discharged from the hospital and immediate follow-up within 30 days. Chronic care management is the ongoing process of working with the patient and working in the community to address that patient's needs. For the community connections that are done, the chronic care manager must document within the EHR record what has been done and the amount of time that is devoted to it. Only one provider can bill in any given month for chronic care management services. And as we mentioned, the billing currently covers Medicare Part B and Medicaid fee-for-service, but Nancy and Lynn, when they talk about the billing that Westshore has done, have a lot more comments about other payers that are accepting chronic care management billings. So with that, I'm going to turn it back over to Dr. Adornetto and Dr. Ridgel to talk about why Westshore committed to this type of program, because believe me, they got into it very, very early. We started talking about this almost as soon as the billing became available. And it is such a wonderful complement to Westshore's approach to holistic care for their patients that it seemed to be a natural fit. But I think it's better to let them say in their own words what they had hoped to achieve and when they structured it, why they opted to go with a nurse practitioner and move ahead with the program. Dr. Adornetto?
Well, you know, the idea of a chronic disease management and transitional care management program came from just discussions that we were having within the group. You know, obviously there's a big focus on reimbursement, on hospitals' readmission rates and how that will affect them down the road. And then noticing that there was problems in the discharge plan, the handoff to the primary care physician and getting the records, you know, updated appropriately, and then the time that was needed to see those patients when they did make it to the office and how much work was involved at the time of the visit. And so we thought that, you know, we started by talking about the transitional care program first because that would be great for patients and our providers. And then, you know, kind of bringing into that discussion the chronic care management as well, and how, you know, we had patients who had multiple medical problems and they could use a little bit more follow-up and a little bit more understanding of where their disease process is in between visits. So that was an easy sell for us. And then when it came to the, you know, obviously now it's a reimbursable program, so we can actually pay for the services that we need to provide these folks. And so it was a very simple decision in terms of, yes, we really want to have that program. The next thing you have to have within a group is to have champions, people who look at the challenge of putting the program together and figuring out how it works out, from, you know, the documentation piece to the interface with patients. And so you have to have a good team around you, and we certainly have that here. We have people who are very interested in being a little bit more progressive and interested in the changes that are happening around us. So that was very simple for us to at least want to move forward. And then it was, again, trying to figure out how to get everything working. We took a very simple problem like diabetes and added the second medical problem, such as congestive heart failure. And if those patients needed a little bit more hand-holding and understanding of taking their medications on time and a little bit more follow-up from a clinician, then that's how we really decided to move forward with the program. Jason, you want to add to that a little bit as to how we came up?
Sure. We chose diabetes as our target diagnosis because of the large volume of patients with diabetes in our practice and the fact that everybody could come to an agreement that great benefit to our diabetic patients having a phone call in between office visits to help manage their insulins and manage their diet and manage their exercise. There's just so many things to do in between visits with diabetes. It's sort of the perfect thing for chronic care management. And that's worked really well for us. We initially started with Irene, who's a nurse practitioner, feeling that especially in the beginnings of this program, we wanted somebody who had a pretty deep knowledge and understanding of treatment as well as diagnosis of medical problems to really take this and run with this, so that when these patients got this call, it was a very high quality call where there could actually be medicine going on during the call. I think we've gotten pretty good feedback from the physicians in our program. We're still fairly new into this program, so it hasn't been months and months and months, but we've definitely had several months, and so far the feedback we've gotten has been all positive, with the exception of some payment issues, which we're going to get into at the end.
I think one of the other, we had nurse practitioners that have been in our practice, and we've been building, again, that program to try to increase the access to our physicians and increase access to our practice. And Irene was with us, and so it was an easier transition for us at the time because she can, as the program's building, she can also do other nurse practitioner, like your typical nurse practitioner work, seeing patients face-to-face encounters while the program built. So it was an easy transition to select a nurse practitioner.
Okay, let's look specifically at the clinical staffing, the issues about getting the program up and running clinically, and specifics as to how patient consent is granted and what some of the requirements are.
So getting the patient involved in the program, there are two potential ways to do this. We figured we could run a report of all diabetic patients and cold call them, which we thought would not get as good a reception. So we chose not to do that. The second method would be, as patients come in with an appropriate diagnosis, the physician who's seeing them identifies that they qualify, they would be a good candidate for this program, and they make that referral. So what we did is we built a clickable little bundle inside our electronic medical record called Westshore Primary Care Chronic Care Management Program. And so when my patient comes in for their general checkup or their annual Medicare physical, and I recognize they have diabetes and several other medical problems, I literally click that, which automatically signs them up for the program. That also triggers a release form to be printed, which the patient signs at that visit. So that's documented and scanned back into the record. The way we manage this list is we chose a chronic disease management ICD-10 code. So that code is selected and put on the active problem list at that moment. And then at the end of the month, we run a list of all patients that have that code. And that is the list of active patients in the chronic disease management program that our nurse practitioner, Irene, then calls throughout the rest of the month.
Can you talk about the interface, Dr. Ridgel, between the patients being discharged that you may be following up on right after hospitalization, and then how that fits in with the chronic care management program?
Yeah, so for the transition to care program, we print the discharge list every day from the hospital, and then those patients who were discharged the previous days get called. And then once that call has been made and documented, a flag is attached to the chart that this patient qualifies for the transition to care code. At their next visit, their follow-up visit, if it's within the 2-week period, they're then coded as a transition to care. At that visit, if the physician identifies that this person is a candidate for chronic care management, they click little chronic care management bundle, that puts the diagnosis on the chart, and then makes them appear on next month's list. Because you have to wait a month before you bill the chronic care management code.
Perfect. Irene?
Yes.
Can you talk a little bit, Irene is really the person that has been designated to make this program go as far as doing the calls to the patients, doing the connections out into the community. Can you talk a little bit about, since you were really the person who brought it up from day one, what you've seen and how it's grown?
Hi, yes, Kathy, thank you very much for having me today. Well, in the chronic care management program, I discuss with patients their chronic medical conditions. So diabetes, like we've talked about, hypertension, high cholesterol or hyperlipidemia, and also mental health issues such as depression, anxiety. I'm able to provide diet guidance and exercise recommendations. There's also been several situations where I've helped coordinate in-house nursing services through the Visiting Nursing Association, and also helped coordinate and set up in-home counseling services for patients that are unable to get transportation and make their appointments to outside providers. So I've definitely been very, very fortunate to have access to those social services to help our patients in that way. Also, during the encounters, I review the EMR very closely and ensure that the patient is up to date with a lot of the primary prevention practices. So making sure that they're up to date with immunizations, yearly labs, and if I note that anything is missing, I can set a reminder into the chart to alert their provider to, look into these immunizations, the labs, in order as necessary. Also, it's just being a connection for the patient. I feel that they feel that they're very, that they're being very well taken care of, and that they look forward to my call every month, and I'll be able to answer any questions that come up within that 1 month period. Also ordering any medical equipment that they might need, refills of medications, blood pressure monitoring kits, diabetic testing supply, anything that they, just eliminates that extra phone call and extra waiting to the office. I can take care of it at that instant.
So it doesn't sound like you have a problem meeting that 20 minutes per month requirement for the vast majority of your patients.
Not at all. Definitely, I feel like even if all of their medical conditions are stable, their numbers look good, they're feeling well, they always have questions, always have needs that I can address, whether it be helping, set up referrals or ordering extra medications, anything, answering some questions. There's always something to discuss and talk about, and it's never less than 20 minutes. It's always upwards 30, 45 minutes. So.
And how many patients are you currently handling in the program?
40. Yeah.
Okay.
So 40 patients. I'm able to coordinate with a lot of agencies in the community, whether it be other university hospitals, Westshore Primary Care Specialists, cardiologists, neurologists, but also the mobile crisis unit I've contacted, the VNA Visiting Nurses Association, like we said. There's also a Benjamin Rose Institute on Aging, which helps with a lot of social services for our elderly population. I've been able to reach out to them several times. Local pharmacies, social workers, adult protective services, there are just numerous agencies I've contacted.
And what do you think their response has been?
Very, very, very positive response, because I give them the background on what I'm needing. If they're not able to help me, they always refer me to someone who can, and I will reach out, and they will also reach out. We'll contact back and forth, and they'll tell me, hey, I've reached out to this patient. We're getting social services in line for them, and it's working out really great. So, and I've done it several times, so it's been great.
Dr. Adornetto?
One of the advantages of having Irene involved with these patients is there are those that have greater needs as providers. You know those patients that call back frequently, and it's when I've referred patients to them, to Irene, they stop calling me. They're calling her directly, and her line directly, and she's getting them the services they need. And she talks to me, and we talk about how we're going to handle issues with the patients, and then they're calling her directly, and she's handling these folks very well. And we have multiple locations, and at my location where she's located, it's acting like a single practice, where she will actually come down and visit them when she knows that they have a follow-up with me, ask them if they have any other needs, and make a much stronger connection. And to our other offices that are not physically here, she still makes the phone call, she still contacts the provider, and just provides that bridge between their outpatient world and when they come to see us. Very nice practice.
Irene, talk to us about how you give feedback to the treating physician or provider that is the primary caregiver for that patient.
Yes. So often if I encounter any issues, obviously if it's an immediate concern, a lot of our providers are accessible just a phone call away. I'll give them a call, and they contact me and we talk about it right there. A lot of times I can send a high priority message in our EMR, which will allow the provider to get back to me in a very timely fashion as well. And then also, like Dr. Adornetto mentioned, I'm right here. A lot of our providers are right in the same building. I can just easily go downstairs and speak directly to our providers who are seeing patients and discuss it immediately. But otherwise, if it's not an immediate issue, I will send a message via our EMR to our providers saying, dear Dr. Adornetto, I have spoken to our patient for our chronic care management program. We discussed this and that, so forth. Please let me know if you have any further recommendations, if there's anything else you would like me to add when I call them next next time. And that way it keeps open communication. The provider will know that I've reached out to the patient for this month, and also my documentation is done in a timely fashion so that they'll be able to go back and review everything, and if they need to change anything or make any adjustments, we can do so.
So the documentation of your call or your communication goes right back into the patient's record?
Right back into the patient's record, and I always make sure to do it within a couple hours of the initial phone encounter, so it's always there. So even if the patient has a question later on that night, they can call and they'll be able to see.
Great.
Yep.
That's wonderful, wonderful insight to hear from the front line. Let's look at the technical side of it. And Dr. Ridgel is really the guru and sets up a lot of the templates and everything in the Allscripts Pro system. So we've asked him to kind of talk about that. And Kaye Gorman and Lisa Martin have really worked on the interoperability piece. So Dr. Ridgel, why don't we turn it over to you to talk about how you feel what you did as part of meaningful use has fed into all the requirements for chronic care management documentation in the EHR, and then what you added to that.
Well, the main things that we added to the EHR were some templates to allow Irene format to document her note more easily. So within Allscripts Pro, we use the reason for visit template system to allow a series of questions to be asked as to what disease are we following up on, what changes have been made, what have you done in the interim, and she can sort of fill in the blanks here and then do a little bit of free text addition at the end of that. So every time she makes this phone call, there's a very nice paragraph documentation that's easily accessible in the EHR at any time and certainly accessible at the next visit. I'd like to also emphasize that when she finds something that she thinks is important, she will attach, in addition to that, a pop-up message. So when that patient comes in for the follow-up next month, as I open their chart before I see the patient, I immediately get a pop-up saying, this patient never went to CGI that you referred to. Stress this to them. And I put her on an exercise program for her diabetes. So I walk into the room and I say, how is the exercise program going that Irene talked about? And this continuity is sort of amazing. And that really reinforces our treatment plan.
They think you have ice in the back of your head.
Precisely. And it's just a little pop-up message.
That's really, that is a wonderful use of clinical decision support to say it's like a real-time support to what's actually happening at that time and customized to that particular patient. So that's really good to hear.
Yeah. Because our program is entirely within our EHR and we have not outsourced anything, we have access to everything 24/7. Other models that we looked at involved outsourcing the calling to another source who would be documenting outside of your EHR and then sending documents back to your HR. But this is a lot harder to manage the 24/7 requirement because then you don't have access to what they did.
Right.
So I would certainly strongly advocate keeping it inside your own system.
Yeah, I would absolutely agree with you there. And I'm sure it's a whole lot easier for the billing documentation, which we'll get to in a minute. Mm-hmm. But Kaye and Lisa, why don't we turn it over to you to talk about the technical component for interoperability, which is basically, first of all, how are you using the EHR to communicate with the patient? And Irene can obviously jump in on this too. And then what are you doing as far as connections in the community?
Well, we really encourage our patients to use our patient portal, and this helps us with the meaningful use requirements, with the secured messaging. Also saves them time for playing phone tag if they're trying to call the office, but they can always call the office and speak to one of the receptionists or to a nurse, to the nurse practitioner or a medical assistant to get the messages across. But that's really helped us, with our patient portal, getting the requirements that way along with it. We also, with the exporting of the CCD for the referrals, exporting the EPHI tool out of our system helps us a lot to get that access to them electronically. Before we began this program, we were monitoring who we were sending and where we were sending our referrals to. So we worked with making sure that those entities and providers were set up with direct messaging in the very beginning. A lot of them were, some weren't, and that's where working with Lisa has come in to help us get those providers that are not set up on a direct messaging or email system to get that information into our system.
Lisa, do you want to talk about how you follow up? I know Westshore was really a good source of information on how to set up in the community, but I think it's important that people understand what you can add and give them as far as chronic care management program to make sure that their high-level connections that they need are actually on some type of electronic receipt of records.
Mm-hmm. Sure. So Medicare does not specify the means of moving the patient information just as long as it occurs in an electronic transfer. Any means is acceptable, and CliniSync provides two different options. As Kaye had mentioned, working with direct exchange, so working with the community partners, other referring entities, long-term care facilities, etc., getting them set up with a direct email address if they don't already have one. Another service that CliniSync provides is that we maintain an ever-growing database of direct email addresses. This is a statewide list that we have. We've got over 15,000 unique direct addresses in there, so we make that available to our participating practices. Another method would involve use of our community health record, which Westshore Primary Care is also looking at. It allows for both patient query as well as publishing the CCD up into our community health record. And with that, we would work, CliniSync would work along with your EHR vendor then to get that set up. You can also work with referrals to a social service agency, although that does not require an electronic transfer, but the fact that the referral was made should be documented in the EHR.
Right, so basically what you're saying is there's two common ways that the electronic referral can be done. So if it's going from a practice to practice or provider to provider, one is what I think Westshore is doing right now, and that is the use of direct email, in which you can help a receiving entity get set up if they are not already on direct email. And the second way, which is becoming more common now, is to use the cloud to push the general summary of care document into the cloud so that subsequently treating physicians can access that and they have the information available.
Correct. Into the community health record.
Right, and but either one of those ways would meet the electronic requirement for chronic care management. So that's good to know. Okay, and just a quick note for those of you who are interested in follow-up on this, here is a map of the state of Ohio with Lisa's counterparts' names for any area in the state where you would like to make sure that your receiving practices need contacts to get connected. But now we get down to the area that I think people are just really interested in hearing about. And Nancy and Lynn are going to talk about the billing side of chronic care management, because this is the area that, between that and the technical, are the two areas that I think people have the most questions about: how it works, you know, what you do to monitor it, are you getting paid for it, are the payers responsive? And so with that, I'm just going to turn it over to the two of you. You probably have as much history as anybody in the state on doing this now.
Well, we've been successful doing this. We have one dedicated coder that works directly with the program, with the chronic care management and the transition to care management codes. And our EHR system and our practice management system are set up to make the workflow very easy for us to do this. Each month, at the end of the month, Irene puts her chronic care management codes into the system, because we have to make sure that, you know, a month has passed, and then Lynn will pull those charges in the interface and look at the documentation, making sure, but we know that the chronic care management has been documented pretty well. We look at those, though, just to to be certain that it's in there.
Yes, we check it all, but her notes are really thorough. It comes right through the last Friday of the month is how we've set it up. So we know when we're going to bill it each and every month. So they all get billed at the same time each month.
So the chronic care management piece is fairly easy for us with such a good documenter, and with Lynn checking that when they come in at the end of the month, it works out really well. The transition to care management requires a little more work on Lynn's part. What will happen is when Irene pulls her list of the transition to care management patients, the discharge people from the hospital, she'll review that, and then she makes her first initial phone call that has to be documented for that transition to care management code to be billed eventually. And then she will flag the physician in the EHR that this patient had the phone call that was required. They have an appointment set up, hopefully within the time frame, the 14 days. And then, she lets the physician know that this patient is eligible to do the transition to care management code when they're in the office. So when the physician picks that code, it comes through our interface. And then when it comes to the interface, any people in our charge entry department see this code, the code that's 99495, they know that that's the code that needs to go to Lynn. And then Lynn takes it from there.
What I double check for on any of them is just to make sure that the timelines have been met, that she's made the call within the time frame, which she's excellent with that. And then also she helps to coordinate those appointments so that they do get into the physician's office within the required time. So she tries to set those appointments up at the time that she makes those phone calls. So I do go in to check the dates to see when it was discharged, that the phone call was done in the right time frame, that it was documented, and that they are coming to the physician at the right time within the time frame required. We typically use the 99495. That's where we find that our patients, our demographics, most of them fall within the 99495.
Okay, and so specifically what you're talking about is the use of the transitional care management codes for follow-up immediately after discharge, and that is billed within the 30-day window post-discharge.
It's actually 14 days.
14 days, okay.
It's billed within 30 days of the discharge, but they have to be
Seen within 14 days, correct. And the call has to be done within 2 business days,
Yes.
correct? So basically, this is the first shot in the door for a patient who has been discharged, and then if you determine that they may be also eligible to be part of chronic care management, then it's necessary to have at that visit to go in and get the patient's consent, and then wait for that billing period so you're not billing both transitional care and chronic care management within the same 30-day period post-discharge, correct?
Yes, and if
Okay.
they happen to be part of our chronic care management and they do end up in the hospital and are discharged, we cannot bill both of them in the same month. So you can't bill transition to care and chronic care management within the same 30-day period.
Okay, that's good. Can you all talk, because I know you've had some experience now, about what reception you've had from the payers? Because even though when you originally set this up, it was according to the requirements for Medicare, chronic care management, but the reality is you have a lot of patients who may also be private payer cases. And what type of reception have you seen? Have you billed everyone? And if so, how is that going?
We build a lot of products. The chronic care management is mostly a Medicare population, but we also build the Medicare managed care plans and the dual Ohio plans, the ones that are Medicare and Medicaid, and we're having much success with those. The Medicare plans and the dual Ohio Medicare Medicaid eligible plans, Buckeye, CareSource, Molina, we're not having any issues getting paid with the chronic care management from them at all. The transition to care management, we are having a little more issues. We're not having any issues with Medicare and the transition to care management. The issues are with the, and it seems like they're resolving themselves slightly as time goes on. Maybe their system wasn't set up properly, or even their customer service representatives and their people that we're calling in to speak to when we get these. We've been watching every single one. We print the list every month, see what the results have been with each carrier. We're monitoring it closely. We're having some issues with copays. Some of the insurance companies at first were, especially the Medicare managed plans, Anthem, Aetna, Senior Advantage, those plans, most of those plans have copays for their patients. And so they've been charging, even though the allowed amount is sometimes greater than their copay. So we've been getting, some information out to the insurance companies, and that seems to starting to resolve itself. Anthem seems to be resolving themselves. We have not resolved it with the Aetna Medicare plans. We're still working with them. And the transitional care management, we've been very successful billing that to many payers and not having any issues at all except for time frame with the Humana. Yes. The Humana Gold product. The Humana Gold product's giving us issues with the 30 days. Even though if the service is supposed to happen within 14, they don't want to see the bill apparently for 30 days. And if you bill it in that 30 days, they're rejecting it, saying that you're billing it too early. So, we kind of learning as we go along, watching each payer. We literally look at every payer every month to see, what's happening. At first, Anthem Senior Advantage was charging copays. Now this month, it looks like the ones that went out in May, they've stopped charging the copay. So, we've been appealing anything that wasn't paid because most of the managed care Medicare plans and the dual plans are supposed to be paying this by the CMS guidelines.
Now, Nancy, when you have to appeal, what do you do? Or how do you set that up? Do you call and talk to them? Do you send them the CMS guidelines for chronic care, or what exactly are you doing?
Actually, it's a combination. We do start initially with the phone call, but as Nancy said, a lot of times with our the representatives that they have there, they don't always understand the program or what it is because it is new.
Right.
And you can call back 3 times and get 3 different answers. So we try to resolve it initially because it's quicker over the phone if you can just take care of it. But most of them we do end up doing a written appeal and sending in the guidelines.
Okay, so that's really what you would suggest is just keep calling back in, and do you use that kind of summary piece that CMS has put out about the program so they understand what they should be looking at?
Yes. Most of the time you have to send them.
We haven't done a lot of written appeals yet, but we're starting to say, now that we're seeing more, we're doing more and more, we're getting prepared to do, appeals every time. This is not something at first, when we were, getting this, we weren't sure how it was going to go and who's going to pay for it, but when we see that they're paying it sometimes, and then other times whoever happens to process that claim isn't paying it, how the system's working. So now we're becoming more aggressive at getting our payments because we know that the guidelines call for that. So, but we've had no issues with Medicare or any of the Medicaid products at all.
That's really good to hear. And as I said, based upon some of the questions that you had originally from the payers, that is something that we hope to do sometime over the summer is get a number of the payers on a webinar to talk about their approach to chronic care management, because I think it would be the other half of the equation, and basically it may increase their learning curve for their employees too, so there's a standard response. So I appreciate hearing how you've been able to do that. That's I know it's been a process. Okay, so to bring it home and complete the discussion, Dr. Adornetto, Dr. Ridgel, and the rest of the team, what would you say your biggest issues were in getting the program up and running?
Probably just wondering and thinking about what the reception by the physicians would be. So you really need physicians who are willing to support a program like this, especially if you expect it to make the investment in the personnel to support it. So that was our probably the biggest hurdle, and educating them, the other providers, as to how important this was for patients and for how it was really going to be a necessary service that we needed to provide. So I think that was probably the biggest hurdle. And then obviously the technical component, which you heard about earlier, but of course you have to have good people who know your system and know how to set it up to make the workflow go easily. I think those were the 2 main things we had to deal with. Jason, anything? Yeah.
Well, I think that sums up what our problems were.
I have to say, when we started working on this, it's been over a year ago, and kind of throwing around what it would take to get it going for Westshore and everything, something Dr. Ridgel said stuck in my mind. You know, as Westshore tried to decide the costs involved, whether it be worth setting it up, and Dr. Ridgel said, we need to set this up, it's the right thing to do. You know, whether or not we get all the billing stuff correct, we need to be doing this for our patients. And I would say that to me is like the mantra here is, you know, it is going to make your patient care better. And Irene, what about, do you feel that the work that you've done the past several months has given you better connections into the community and Westshore generally? Do you feel like it's both helped you help your patients, but also made the community providers aware of what you do?
Yes, I definitely feel that this program is beneficial not only for us as providers here in the Westshore Primary Care community, but also extending out to our colleagues who are outside of, you know, Westshore Primary Care or UH as well. I've spoken to several doctors personally as issues have come up outside of our practice, and they tell me, wow, what a great program you're doing. Why isn't everyone doing this program? So, I mean, really, the reception has been very positive, and I feel like our connections are very strong, and they will only continue to get stronger and better as we move forward in this endeavor. So, I'm very looking forward to it. I'm very pleased and honored to be part of it. So.
And do you feel it's giving you a better handle on your patients' needs generally?
Oh, yes, because, I mean, a patient encounter is 20 minutes and you can only cover the surface, but I can get a lot deeper with these patients and see their actual, the social needs that, you know, cause them. Why did they miss that appointment? Well, I know that they don't have transportation. So I can help facilitate, you know, at least make some of their calls, you know, in home and help with that kind of issue so that they're not missing their appointments. Remind them, call them, say, remember you have to set up transportation to come to your appointment in a couple weeks with Dr. Adornetto. And I really feel that getting to the bottom of those social issues, not only medical issues, but social issues, helps with the continuity of care and, you know, coming to their appointments and being in line. Yeah.
So any last thoughts, Dr. Adornetto, Dr. Ridgel, team?
I think the value of this program is obvious from Irene's comments, and I can certainly echo being on the receiving end of this. The improvement in the continuity and quality of care of my patients that are part of this program is dramatic. We all know that the gaps between visits, the gap between hospital and the office is a huge area for terrible medical care and things falling through the cracks and not getting done. And these extra phone calls go a huge way to making up for that and preventing those problems from happening. We were very nervous about being able to pay for the service because we live in a world where you do have to pay for what you're doing. We can't just give away services for free. But I think that it's very encouraging that we are getting paid for these services, and we do clearly foresee the ability to increase the number of patients in this program and pretty easily cover our costs in a fairly short amount of time.
Perfect. Perfect. Well, thank you all so much. I can't say enough good about what Westshore has done. I think it's just been incredible to watch it grow in such a short period of time. And with that, I'll turn it back over to Scott and see if he has any questions from the audience that were not addressed already.
Cathy,
Scott?
Yes, we do. We have 3 questions. The first question is, does the provider sign off on the chronic care management note in the EHR?
That's a very simple answer. No. There's absolutely no reason for the provider to just sign off on that note. If there is routine medical care and advice being given, our nurse practitioner simply documents it and puts it in the chart so it's visible at the next visit. If there's any actual change in the medical care or there's something felt that she feels needs to be addressed, she sends a message directly to the provider.
Okay, the next question is, how many phone calls on average are you making for transitional care management in a 30-day period?
In about a 30-day period, I would have to say, so maybe like upwards to 60, 70, depending on each call could be, the transition of care, they could be either pretty simple, everything's going well, or one call could be up to an hour long, just depending on what has happened during, during hospital staying with discharge issues. So it kind of depends, but I would say probably 60, maybe upwards to 70 if the calls are a little easier in the 30-day period.
There was also a follow-up question to that as well. How many calls to the same patient are you making in the same 30-day period for transitional care management?
Oh, to the same patient. So yeah, there are some patients that unfortunately I do call monthly for the transition to care for the hospital stay. But other than that, I mean, there's only few that, maybe 2 that stick out to me that are frequently in the hospital.
So, and what about on your chronic care side? Do you find you're talking to the same patient maybe a couple times a month about lab stuff or follow-up, making sure they're making appointments and stuff?
Mm-hmm. Like, I would definitely say, so chronic care management, I have the same list that I work off of and any additional ones that come in monthly, but they're pretty much separate. I can't say that a lot of my patients from the chronic care management list are frequently in the hospital. That's a separate patient population.
I think with chronic care management, some patients will require multiple phone calls, but most of them just appreciate the call in between to kind of go over the medication. The transition to care, the idea is to make the phone calls, make sure that they have everything they need after their discharge, set up their follow-up appointment, make sure it's scheduled, and then we try to get them into the provider as quickly as possible to prevent some repeat phone calls for that program.
Scott, does that answer your questions?
We have a couple more.
Okay, sure.
How are the patients reacting to the copay for chronic care management if they don't have secondary insurance?
Nancy? Copay?
We haven't had any issue with that at all. We've had one issue with the Aetna patients that had a copays. That's where we realized that we were billing the patient after that because they had a $40 copay, and they don't want to pay that. But the smaller amounts that, maybe $2 or $3 charges that are covered, and I don't have a lot of patients actually that just have Medicare. Most of them are in those dual eligible programs, and the other $6 is covered by the Medicaid portion of their dual Ohio plans. So anybody who doesn't have a secondary usually has a dual plan with the Medicaid plan, so we haven't had any issues.
When we briefly introduce the patients to the program, we do explain about that there may be a copay associated with it, and we try to work with the patients on that.
Scott, I viewed another one.
Yes, ma'am. Has the program been ongoing long enough to show any improvement in any related clinical quality measures?
I don't think it's been going on long enough to show clinical outcome changes. Most of what we have is anecdotal reports of improvements, patients who maybe didn't run out of their medications at the next visit, knew what their when they came in the next time, what their medications were, had a better understanding of that. So that's more, the providers know that information, but we can't quantify that or really give you a formal report on that.
Yeah, and I think we can at the end of this year, because Westshore set this up to the beginning of the year, that because we track, for example, diabetes A1C and some of the more common hypertension measures and stuff yearly with Westshore for meaningful use in PQRS, that we can look at it again at the end of this year and have a better sense of if there's been any significant improvement at that time.
Well, Kathy, that was our last question.
Well, all I can say is thank you to the team here. They are fabulous. As you can tell, they are extremely knowledgeable and extremely patient-oriented in their care. And thanks again for everything. Thanks to Lisa for coming in and talking about the community connections. And if you have any questions, the questions page is up, and you're more than welcome to contact us. And if you have specific questions for Westshore, we will put you in touch with the folks here who were on the webinar. Thanks again, everyone. Have a great day. Enjoy the weather.